Pharmacoeconomics of metastatic colorectal cancer treatment with target therapies guided by companion molecular diagnosis. To guide the treatment with monoclonal antibodies against the epidermal growth factor receptor of metastatic colorectal cancer, the FDA recommends pure companion molecular diagnosis. It initially recommended screening for mutation in exon 2 of the KRAS gene, and most recently to extend the screening to exons 2, 3, and 4 of KRAS and 2, 3, and 4 of RAS genes. Furthermore, to evaluate the BRAF exon 15 mutation status, including B600E. To date, no studies have been done to compare the cost benefits of these different CMDx. Our hypothesis is that using the extended RAS and BRAF CMDx generates savings in the treatment of patients with metastatic colorectal cancers. The cases were diagnosed in our laboratory before 1916 were genotyped with the standard RAS CMDx, while those diagnosed later with its extended version. The resulting genotypes were registered in our database. The estimation of the mutation prevalence for the 10 hypothetical case model was based on the prevalence obtained in the screening for mutation in the RAS and BRAF genes of tumor biospecimens, a specimen in which only KRAS exon, second exon mutations were genotyped were excluded. We performed pharmacoeconomic calculation by taking into consideration treatment costs mainly. The case scenarios were constructed in group of 10 cases to estimate the cost of target therapies and its outcomes. In the first scenario shown in Figure 1 and the Table 1, the treatment of all clinically diagnosed cases with MAPS without the benefit of prior CMDx testing will result in a waste of money and time for half of the treated patients. This scenario reflects a total expense of $1,225,864 for the 10 patient cohort. In the second scenario, treatment is guided by the standard CMDx testing. In this scenario 3, and requires patient will have been identified as having tumors harboring RAS exon 2 mutation, and the remaining 6 are acquired as wild type. Only the later group will receive MAPS immunotherapy. However, in the subgroup, approximately 2 patients will harbor mutation in exon 3 or 4 of KRAS, exons 2, 3, and 4 of RAS, or exon 15 of BRAF. Compared with the first scenario, there will be savings of $397,990. Finally, in the third scenario, the recommended treatment is guided by the extended version that will identify with better accuracy the 4.5 true wild-type RAS patient, as well as the help-carrying BRAF mutation that will also benefit from the personalized target therapies. In these patients, there will be saving of $112,373 compared to the second scenario. In conclusion, the comprehensive analysis of the mutational status of patient tumors revealed a considerable proportion of cases whose target therapy turned out ineffective if guided only by the standard KRAS CMDx. The use of the extended version to guide the application of target therapy can result in considerable savings of resources and can allow valuable time of the selection or alternative treatments.